morning to all of you. Now let us see what kind of wounds we can proceed for internal fixation and what kind of fractures we need to stabilize with external fixator. Here is a patient with a simple wound, no contamination, simple fracture. We can proceed for intramedullary nailing and we can achieve a good outcome. Vertical wounds and oblique wounds where when there is no soft tissue loss, we can easily close them up without any problems. And in those situations, we can proceed for internal fixation and then achieve an outcome like this. However, a comminuted fracture in the proximal tibia region where the muscle damage is high, even after primary closure, sometimes immediate internal fixation may not be possible. In those situations, we can stabilize with an external fixator initially and then followed by conversion to internal fixation once the wound heals completely, and then we can achieve a good outcome. The external fixator is a workhorse in the management of open injuries. Whenever there is a doubt, better not to proceed for internal fixation. External fixation will equally give a good results. And sometimes if the alignment is good after the wound heals, we can retain them till the callus starts forming, and we can use this as a definitive external fixator itself without advancing for secondary procedures. Any sutured wound, when they present to us, better not to leave it like that. Take the patient for debridement and proceed for fixation. No sutured wound from outside, we can leave it. So there is a possibility of infection. Here we can see that there is a soft tissue loss, and comminuted fracture, always better to put an external fixator initially, and once the soft tissue healing is achieved, we can proceed for definitive fixation and achieve a good union. As earlier told, two small wounds, which indicates that the energy is very high velocity injury. In those situations, better to choose an external fixator rather than internal fixation, so that we will get a good results. In this situation, we can see that the zone of injury, actual zone of injury, is quite high compared to what we see on day one. This patient required multiple procedures and we achieved a good outcome. Whenever a patient presents to us with a small wounds with a large skin degloving from knee joint to distal tibia, it is better to avoid internal fixation. Always choose an external fixator which is simple and keeps the problems very low. Here the patient has undergone intramedullary nailing on day one, and we can see that the degloving is quite high on day one itself, and it went on to have a multiple procedures, resulted in bone loss, and he required 5 additional procedures for the limb salvage. A projecting bone like this, better not to do reduce in casualty, and we need to proceed for as early as possible debridement and administration of antibiotics. And here the wound is on the medial side, and if we are happy with the adequacy of the debridement, the single most important criteria on day one is debridement. If it is adequate, if you feel that there is no contaminants left over, adequately removed all the devitalized tissue, we can proceed for a day one plating, which can give a good results like this. So one need to remember about small wounds with a gross underlying muscle damage, like compartment syndrome, which can result in, if we don't address them properly on day one, there is a possibility of infection, which further results in bone loss and requiring multiple procedures. So small wounds should not be neglected, and always look for the compartment syndrome, and because subsequent complications are quite difficult to manage. Whenever a patient presents to us with small wounds with a large fracture, comminuted fractures, always think that the patient's dynamics, the blood pressure and other injuries we need to rule out. Many of them presents with a polytrauma situation. In those situations, damage control procedures are very important. Debridement of the wounds and then damage control procedures on day one. And once the patient is fit for subsequent procedures, we can proceed for definitive fixation and achieve good results. In contrast to the lower limb injuries, upper limb injuries with small wounds with a gross comminution like this, after the adequate debridement, actually we can proceed for internal fixation on day one. Majority of the upper limb fractures, we can proceed for internal fixation on day one and then proceed for soft tissue cover. And this fracture went on to heal without any problems after good soft tissue cover. So to conclude, Ganga Hospital Open Injury Severity Score, total score, if it is 9 or less than 9, always proceed for fix and close. Fixation means even external fixator also is a method to stabilize the bone. Any form which stabilizes the bone adequately can be adopted. And if the score is 10 or above, which indicates that the velocity of injury is very high, we need to adopt for staged procedures. In staged procedures, external fixator is a better method to stabilize the bone. Upper limb injuries, plate fixation is always preferable. And one need to be very careful about the degloved skin when there is a small wounds. And if one wish to read about open injury management further, we have written a chapter in Rockwood and Green 9th and 8th editions. We can read that. And there is an app available in the Android version which tells us the primary, how to score, as well as the final outcome, like how many patient takes to heal, and what will be the outcome, how many admissions patient might require, and how many secondary procedures patient might require, and ultimate union time. All the details can be derived by this app. Thank you.